This is an introduction to the 3R's approach to back rehabilitation, and this is a clinical framework to guide therapists and exercise professionals through the process of constructing exercise programs for those recovering from low back pain. So the first question I suppose we should answer is, why is this necessary? Well, the first thing is to look at the nature of low back pain and the nature of the problem which it causes in terms of suffering and disability. So about a quarter of the population at some stage will get low back pain, and of those, the vast majority, so 95%, are diagnosed as non-specific low back pain. In other words, it's pain which is not specifically related to a single structure which can be treated. And interestingly enough, 2/3 of those individuals will go on to have recurrence of the same or similar pain within a year of the first incidence. And a lot of research has gone into why this is the case and why low back pain is caused. But unfortunately, disability levels have failed to improve as a result of this research. Now, when we look at the scientific research and the trials that have been conducted, the National Institute of Clinical Excellence recommends several different things in terms of treatment. The overriding one is that exercise is a key modality in the treatment, in the management of chronic low back pain, and that other forms of therapy which have been popularized, such as manual therapy and pain neuroscience education, can be used. They are effective, but they should only be used as part of a treatment program involving exercise. And these programs should focus very much on getting the patient to be independent, to getting them to manage the condition for themselves. And if we are using exercise, we must recognize that no one single type of exercise is superior to another, but one may suit a patient better than another. So we need to consider patient needs and patient requirements when we are prescribing an exercise program. So when we look at those three common treatments then, exercise, manual therapy and education, let's see if we can just cut through some of the fact and some of the fiction here. So some of the common beliefs, some of the popular beliefs about these treatments. So if we take the center column first, manual therapy, it is something which is becoming less popular within the therapy professions in general, because the evidence of its effect as a standalone treatment is not particularly good. However, although the evidence of its outcomes is not particularly good, patients rank hands-on techniques as being very high priority. So they see hands-on techniques as being something which is desirable. And that's perhaps because hands-on techniques have been shown to enhance the therapeutic alliance, and that is the connection between the patient and the therapist. So we also know that any effects that manual therapy have can be enhanced by education, so PNE, pain neuroscience education. So we have both specific and non-specific effects within manual therapy, and we also know that when we are using manual therapy, it is in itself not specific to a particular tissue or a particular region. So we know that the non-specific types of manual therapy are less skilled perhaps, but are equally effective in terms of treatment outcome. When we look at pain neuroscience education, PNE, what we're trying to do is to educate the patient away from this belief that if something is hurting, something must be wrong within the body. So we've described the vast majority of back pain as non-specific low back pain, and yet patients will often try and fixate on something. Is it a disc? Is it a nerve? Is it a joint? Has something gone out of alignment? Is it something that I'm guilty of, something that I've done, a particular movement that I should avoid? So we're trying to say to them, well, it is possible for something to hurt without there necessarily being something wrong, something mechanically wrong. So we're trying to de-educate this link between hurt and harm. And that's important because patients will often avoid movements which are painful or movements which they perceive as potentially being painful, the so-called fear avoidance model. So pain neuroscience education is important, but when it's used as a standalone treatment, the effect sizes are relatively small. But where it's used to strengthen the therapeutic alliance, it is very useful. So when we look at our third treatment type, then our third column of exercise, we can say that exercise is effective, but no one type of exercise is necessarily more effective than another. So we tend to have camps of people who believe in core stability, or people who use Pilates, or people who use extension movements, or different types of movement. But when we look at these and we compare one to the other, we can say, well, it is the act of participating in exercise rather than the specific exercise which is important in itself. So the pain or the disability that the person is undergoing doesn't necessarily relate to a change in the musculoskeletal system. So if we're doing a strength exercise, we would expect to see an improvement in strength, and indeed we do. We see that adaptation. If we're doing yoga, it might be an improvement in flexibility. If we're doing Pilates, it might be an improvement in core stability. But that musculoskeletal improvement is not related to the reduction in disability. What is related to that reduction is simply the fact that the person is engaging in a movement, engaging in an exercise, and that several different types of exercise are often better than a single approach because we're likely to hit on one which is suitable for a particular patient. And exercise is important to treat the condition, but it's also important because it can help to prevent recurrence. So exercise where we combine strength and stretching with aerobics exercise on a regular basis has been shown to reduce the recurrence rate of low back pain by about 1/3. So exercise is vital in terms of treatment of the initial incident and also important to stop recurrence. So why is it then that several different approaches are important and manual therapy, education and exercise are important types of treatment? Well, it comes down to the models that we use, that we base our treatment on. And the traditional biomedical model links a pain to a mechanical change in a predetermined way. and we would therefore say that pain is related to a specific structure. If there's more pain, then the structure is more effective, and as pain starts to reduce, things are improving. So we would target the specific structure with a specific modality and we're using a model which is essentially first described for surgery. So something is painful, treat it or cut it out and the pain will go away. Now this contrasts with the biopsychosocial or BPS model, which recognizes the importance of tissue, the importance of biology, but also says, well, that biology exists within a patient. So part of that patient is going to be the psychological effect that that injury has, and part of the importance is going to be how that injury and that psychology affects the person in their current work or leisure environment. So we've got an integration of biology, psychology and sociology, and all of those factors will come into play at some stage of our treatment. So using this biopsychosocial model, then we can say that there are several factors which will interact in the development and the maintenance of chronic low back pain. So in terms of the biology, we've got things which are physical, so strength, flexibility, etc., and also comorbidity, so obesity, chronic fatigue, inflammation. Where we've got psychology, we've got psychological factors such as fear, anxiety, depression, but also things which are less general but are more specific to low back pain. So the belief system, whether the person believes that a pain is an indication of something bad which is happening, so catastrophizing. These types of things will affect the person's psychological confidence or self-efficacy. And then how do these biological and psychological factors affect the patient's life? So their lifestyle may be affected, so they may be inactive, they may have sleep disturbances, they may have life stressors which either cause or are related to low back pain. Job status, pressures of family, pressures at work, for example, will be related as well. So sociological factors are important in the development and also the management of low back pain. So in terms of the development, if somebody is in a job where they're having to perform a particular mechanical technique, reaching and lifting, for example, we would need to take that into account. Equally, when we're giving an exercise program, it's no good saying to someone, go to the gym each day if there's no gym within 20 miles of where they live. So sociological factors important in development and management of chronic low back pain. So we're not dealing then with the human body with a mechanical system. So if we take a car as an example, if that car is injured and the wheel falls off, we've got a three-wheel car which is not going anywhere. But where we take the body, in this case our dog, if we remove one of the legs through injury, that's not the end of the story. The body can adapt, and over a period of time, if we allow that adaptation, it can thrive and it can function normally, which the car can't. The car can't run on three wheels, but the dog initially can't run on three legs, but will learn to adapt its behavior, will learn to adapt its musculoskeletal system so that it can do. So recognizing the living system's ability to adapt, we need to adapt our treatment accordingly. So many treatments take on board this medical model of trying to affect a single structure, which initially comes from medicine, giving a single drug or giving a single form of surgery. So if we take a structural approach, we would say there is an obstacle to the healing. So there's a fault in alignment, for example. There's a tight joint, something is out of place. All we need to do is to target our treatment on that obstacle, and the body will naturally heal itself. And that's what most manual therapy techniques do. But the manual therapy techniques themselves actually lack the force and the specificity to do what we think they're doing. And yet they're effective, but they're effective because of the psychological and the sociological factors which are involved. So contextual effects are equally important to mechanical effects. So changes in structure do not necessarily make a better form of exercise. But when we look at the process of adaptation that the body is going through, perhaps we have a closer answer. So we know that the body is going through a repair technique. So we're going through inflammation, repair, regeneration. So we have acute and we have subacute and we have chronic differences. So we have a healing timescale that we're going through. And we need to recognize that and allow the body to go through that healing timescale. So the dog, when it loses a paw, cannot instantly run on 3 legs, but eventually it will adapt. So we need to allow that adaptation. So we've got phases of healing and processes of healing which we need to recognize. So the 3R's approach then is a clinical framework which takes knowledge from the therapy world and compares it and combines it with knowledge of the exercise world to try to come up with a framework which can guide us, recognizing the adaptation of the body, so the healing time scale. So the 3R's approach is a guide to what to give and when to give it, and to combine this skill and expertise of therapy and of coaching. So it's an evidence-based approach which is evolving as evidence changes. And there are 2 factors which are of overriding importance in the 3R's approach. So the sort of basic concepts, one of which we've covered, is the healing timescale. That the body will adapt, but it's going to go through that adaptation over a period of time. And we would need to recognize that. So the exercise or the form of treatment that we give 2 days after injury will be different than the form of treatment which is required 2 months after injury. We've all had patients where they've been given a technique to do, and 6 months down the line they're still doing the same technique, and we say, well, you know, it was right at one stage but it's not right now. And that can often be something which is important in terms of education. You know, I was given this exercise to do by my therapist and I'm still doing it because I have faith in my therapist. And unless it's not being explained to the patient to say, well, you know, your body will change, and as your body changes, so the treatment has to change as well. So there's a mechanical change, but also there's a psychological change. So the psychological state that the patient's in immediately after injury, they come out of the garden having injured their back, they're panicking, they've got raging pain in their back, and it's going down the leg. So that psychological state will be very different to the psychological state in 2 weeks' time. So the phases of healing and the biopsychosocial approach apply to that healing timescale? So what is happening mechanically, what is happening psychologically, and how are they learning to cope sociologically? So the next concept then is that tissue has an ability to adapt, but it also has a capacity. So if we say, I'm going to drop a small weight on your foot, that's going to be annoying if I drop a couple of ounces on your foot, because the foot has a capacity to withstand that. But if I drop a thumping great big cannonball on my foot, that weight of the object exceeds the capacity of my foot, and so I end up with bruised soft tissue and broken bones. So overload simply means that we are exceeding the capacity of the tissue. Now we need to know the capacity of that tissue and whether the tissue has the ability to cope with the stress placed on it. So if it doesn't have the ability, we have to increase its capacity. So you may say, well, I can't increase the capacity of my foot, I can't strengthen it that much, but I can put a boot on which will protect my foot. So if we can't change the tissue, we need to change something else to allow that overload. So we want a balance, we want a homeostasis between breakdown or damage to the tissue and build up of the tissue. And when that homeostasis is disrupted, it can be disrupted in two ways: by a single large force, so cannonball dropping on foot, or multiple small forces. So if I take a stone and I drop it on my foot and I do it again and again and again, by the time I get it to 1,000 or 2,000 stones, then I have caused damage to my foot. So the other thing that we can do to stop that damage is reduce the loading. So if I reduce the size of the cannonball, there'll be less damage to my foot. Or if I strengthen my foot, there'll be less damage to the tissue. Or if I put a safety boot on, then I'm compensating for that load. So we have both physical and psychological things that we can do in terms of our biopsychosocial model. So we're going to be building up physical resilience, but we're also going to be building up psychological resilience. So the 3R's approach has 3 stages: the reactive stage, the recovery stage, and the resilience stage. And broadly speaking, we're saying, well, the tissues are reacting and the patient is reacting initially, so we're just trying to put the fire out. We're trying to calm the tissues down, calm the patient down. As things start to improve, we can start to get back into activity. We can start to do things which are tailored to that patient and to that patient's condition. And ultimately, we need to toughen the system up. We need to build both physical and psychological resilience so that we can stop the injury recurring. So in the first phase then, the reactive phase, we've said that we're firefighting. So what we're going to be doing here is looking at the potential for serious injury. So we're going to triage for red flags, so things which would point us into a direction where we say, well, we need more information, and also yellow flags, so things that would point us in a direction to say, well, there could be some psychological changes that we need to be aware of. We're going to consider a therapy, any form of therapy, which is going to target pain. So it may be medication, it may be manual therapy, depending on the skills of the therapist. We're going to try to relax and reassure the patient. So both physically, in terms of getting the muscles to relax from co-contraction and spasm, and psychologically by supporting and educating the patient. We're going to encourage relaxed movement, so that we're enhancing both the treatment and the wellness of the patient. So we're going to try to get them to be able to cope, and so we're looking at psychology and sociology here. So we're saying, well, build some form of exercise in for a short while, just go out for a walk, relax yourself, take the phone off the hook, just let somebody else look after the kids, let your husband or your wife look after the kids, allow yourself time to recover. We're going to try to reduce the sensitivity of the tissues. So in terms of our red flags then, these would be things which would indicate that further investigation is required. And we would look in 4 areas. So the potential where we've got low back pain of cauda equina injury, potential of spinal fracture, of carcinoma, and of infection. So that is obviously a whole lecture in itself, and therapists will be aware of those red flags. Exercise professionals will be less aware of them. And yellow flags are risk factors for developing long-term disability, so psychosocial barriers to recovery, belief systems, behaviours, social withdrawal, for example. And again, this would be a whole lecture, but therapists should be aware of yellow flags. Exercise professionals will be aware of them, but not necessarily in this form. So if you're a personal trainer or a coach, you'll be very aware of what works with particular athletes, but it may not be presented in this form. And when we're initially triaging the patient, a screening tool can be useful. So this is the Start Back screening tool, which essentially is a series of questions, 9 questions, and those questions relate to physical changes and they relate to psychosocial changes. And depending on the score, we can say, well, a person is at low, medium, or high risk of developing psychosocial problems and therefore requiring further forms of treatment. So the Start Back screening tool is something which is quite useful for both therapists and exercise professionals. So what are we going to do with our patient? Well, we're going to choose a therapy which is designed to reduce pain, and it really doesn't matter what we do. And it may be a hands-on technique, it might be using acupuncture, it may be using machines, it might be using medication. The important thing, I think, is to define something which is effective with a patient, so it's patient-specific treatment, and something which is acceptable to that patient's belief system. So we don't want to be challenging their belief system at this stage, because they're very frightened. So if they come in saying, well, last time I went to a therapist and this worked, we may well use it. So the argument there is always, well, we don't want to get the person to be reliant on the therapist, but I think in the early phases that's not likely to happen if that therapy is given appropriately and given with appropriate education. So we may have to protect the area, and again, we use the analogy of the Callan ball dropping on the foot and putting a boot on. Well, there's no reason why we shouldn't use taping or some form of lumbar support to ease pain, to allow that patient to function more freely, to allow them to sleep better. And again, it's often said that these things will cause reliance, but providing it is given with the right education, that shouldn't happen. And we use some form of rehabilitation to prevent deconditioning without increasing pain. So it may be that we say to an individual, well, okay, you can do some gentle walking. You don't need to rest completely. You can do some gentle walking, providing that doesn't increase your pain. If it reduces your pain, then that's fine. You used to be using a gym, you used to be running, but just for this moment, what I want you to do until things settle down, I just want you to go for a walk. Maybe that we're giving them some form of relaxation training. And again, it might be a little bit of a sales pitch, so we're not going to get them to do meditation or mindfulness or yoga type activities if that's something which they're resistant to. But we might say, well, just use some breathing to allow your muscles to relax. Your muscles are in spasm, they're too strong, let's just try to release them. Then we've got some form of low back activity as well, which causes the pain to reduce. So just briefly, some examples: we might use heat, we might use ice, something which works for them, just a hot water bottle, some form of rest, teaching them about how best to rest. So how long do they need to rest? How often do they need? What position do they need to rest in? We might use taping, we might use some sociological changes. So we say, well, when you get into your car, just do it slightly differently. When you're sleeping, just do it slightly differently. Postural changes, again, people get very hung up on posture, what's good posture, what's bad posture. But in this acute reactive phase, we may say, well, just for a short period, how about when you're typing in your computer, changing things, putting your laptop on the work surface in the kitchen and just working standing up. You're not going to do it for many weeks, but just do it for a couple of days. It may feel easier for you. Try it. If it feels easier, do it. If it doesn't feel easy, it doesn't work for you, well, don't do it. Just take a common sense approach, and we can do that with all sorts of functional activities, some sort of patient education to get them to cope. And again, these things will be familiar to therapists, but they may not be familiar to exercise professionals. And I think, the exercise professional has that ability to talk at length to the patient, which the therapist may not have. So I think these are things which are important for exercise professionals as well. So things start to show signs of improvement, and we move from the reactive phase to the recovery phase of the 3R's approach. How do we know when we're moving from that? Well, because the pain and the fear of the movement should be reducing. So for the sake of argument, we may say, well, initially it was very painful to walk, but now, I've come back, I've done it for a few days, and I'm up to 5 or 10 minutes walking. Can't do any more than that. It starts to hurt a little bit, but 5 or 10 minutes is okay. And when I got out of the chair, it was really painful before. I had to get somebody to help me. Now I can get out of the chair unaided. So these are signs that things are starting to recover. So what we now need to do is to change our approach. So the things that worked in our reactive phase will no longer work or may not be as appropriate in the recovery phase. So there'll be some overlap between the two phases. But broadly speaking, the approach we're taking is one of exercise. And in the same way we say, well, you've started lifting a 2 kilogram weight, now that's become really easy, we need to increase that to 6 kilograms. And there would be two problems there. So firstly, if we don't increase it, strength will never increase, so the adaptation will stall. But equally, if we give you a 50 kilo weight to start with, it's too much for you. So we can do too much or too little. So we're going to teach the individual that movement and loading are actually good for the spine. So initially we said, well, just be cautious, don't move your spine. We've given them a spinal brace and stop the movement. Now we're saying, well, things are recovering. So now actually when we move, things improve in your spine. So, it's almost as though we're lubricating the spine. We're stopping stiffness, we're strengthening things up. We explain about the concepts of progressive exercise, and also we use coaching. So not just what movement we're doing, but how we teach that movement to that specific patient, because we're trying to reduce the fear of movement and build confidence. And we often do this using techniques that exercise professionals will be familiar with, but therapists will be less familiar with. So let's take a brief look at those. So I often explain this to patients as building fitness in your back. So we are trying to do relatively simple exercises that we're going to gradually make more challenging. And we've got a number of models that we'll briefly touch on here. Firstly, the one of progression, of the fact that you will respond and then adapt to a training. And if we give you too much, your adaptation becomes a maladaptation, and ultimately you can be injured. But if we give you too little, again, we've got no adaptation at all. So in that green zone, we want something which is sort of just right, really. We want to overload those systems so that things start to improve. And that overload can be described using the FIT mnemonic, so frequency, intensity, time, and type. So how often are we going to do the exercise? Are you going to do it every single day, or 3 times a day, or once a week? How hard? What is that intensity? And how do we measure that intensity in terms of the patient's perception? How long are we going to do the exercise for? And what type of exercise are we going to use? When we talk about back fitness, we can make it easier for ourselves by talking about S factors. So we can say, well, strength is an S factor. So we remember strength, but of course, strength could be concentric, it could be eccentric, it could be isometric. We've got stamina, suppleness, strength, speed, skill, structure, spirit, and specificity. And every exercise will have a component of those. So spirit, for example, would be the psychological aspect of an exercise, giving that person confidence in that ability. Strength may be enhancing your ability to lift a weight. Speed may be something where we're trying to lift the same weight but do it more rapidly. So we've got our S factor of fitness. So we've got some examples of some simple exercises here, and these are classic exercises originally taken from my book on back stability from years ago, but these are often called core stability exercises, or Stuart McGill, an author from America, calls them his big 3. And they're simple exercises to say, well, essentially the back is a drum, so let's not move the back too much initially because it's irritable and because it's reactive, but we need to strengthen things on the front, on the back, and on the sides. So we need abdominal strengthening, we need spinal extensor strengthening, and we need oblique strengthening. And as we do that, we want to strengthen the back, and we want to strengthen around the hips, and we perhaps want to give some form of education about how the body moves and about body alignment, because in the reactive phase, alignment may be important and less important in the recovery, and finally very rarely important in the resilience phase. So we're using some classical techniques and some sort of techniques which can be given or defined as being old school, but I sort of remind you that some of these things which are considered as old school are often things which are very important, and although research moves on, some things we need to leave behind and some things we need to carry on. So as we go through our recovery phase, we're contradicting ourselves slightly, because in the reactive phase we've made us say to the individual, well, when you bend forwards, you're telling me that you get pain in your back and it goes down your leg. So I'm going to tape your spine up, and I don't want you to bend forward just while you're recovering. Now we're going to say, well, I want you, now that things have started to improve, to introduce a little bit of bending in your spine. So it's been protected, now we can start to bend it. And this is important because if that individual hears our advice in the reactive phase and doesn't come back, they will develop a fear of movement, kinesiophobia. And that can be very, very important and is something which we need to avoid. So we don't want to demonize low back pain. We want to introduce it, but introduce it progressively, both in terms of the physicality and the psychology of the exercise. So here we've got examples. This is a standard hip hinge movement, so we're using the pole to keep the spine dead straight to start with, to give some education about movement around the hips as opposed to movement of the spine, to know what the difference is. And then as we move into our recovery phase, we're gradually going to reintroduce bending, and we're not going to go from saying, well, don't bend because it hurts, to touch your toes 100 times. We're going to gradually introduce that bending to lengthen the tissues out, to enable the patient to gain confidence so that they don't have a fear of bending, so that they can bend in a flexible manner, in a controlled manner, without having to think about it. And we're going to progress exercises. So as exercises become easier, we simply make them harder. So in this first exercise, we're lifting the arm, and then we're lifting the leg, and then eventually we're lifting both arm and leg. And initially we might lift just backwards to the level of the mat, and eventually we lift to the horizontal. And the same is true of all of these movements. So we're thinking about our S factors of fitness and saying, well, which of those factors are important at this particular time? And eventually we get to a point where all of the exercises become easy and the patient typically would be discharged. The problem there is that they may not be psychologically or physically resilient. So the resilience phase is the phase really between rehabilitation and general exercise performance. Now this will be familiar to an athlete, but it may not be familiar to a general patient. So they may come back and say, well, I did all the exercises, I used the Cliniband and it was pain-free, and I did my walking, and I went out and I did 2 hours gardening, and then my back's gone again. Well, it's gone again because we overloaded the tissues and the tissues weren't able to cope. So the resilience phase is going to overcome that. So we're progressing from phase 2 when they are more or less pain-free and they've returned to their typical daily function. And obviously that would be hugely dependent on whether they sit behind a desk in an office or whether they work on a building site. We're improving and increasing the variability of the exercise, and we're trying to enhance movement confidence, and initially we're trying to very closely instruct or coach the patient, and now we're gradually allowing them to do things more for themselves. We're increasing the physical capacity of the S factors, so whether it's strength or flexibility or stamina, for example, but we're also introducing increasing the psychological effects. So we may well be using physical things on individual muscles to start with, individual body parts, and now we're doing full body conditioning. Now we're moving on to more movements which mimic what they're doing in their daily life, so functional movements. So we're trying to change the exercise, change the environment, change things, mix things up to get them to have confidence in their own ability. So people are often familiar with the fact that as an exercise gets easier for you to perform, you would increase the weight, or if you're doing a toe touching exercise and you can only get to your knees, you would gradually move down your shin. So physical changes. But psychological changes are less familiar, and resilience deals with both. So resilience is simply the capacity to recover quickly from a difficult situation. So sort of mental and physical toughness. And the confidence in the person's ability, their ability to perform a movement, and for them not to hesitate, is something which is vital. So we might say to them, well, I'm going to strengthen your legs up by slowly performing a squat movement in a gym. Initially, you're standing and sitting from a chair. Now we're giving you some dumbbells and you're performing a squat, and we discharge you. But have we ever said to them, well, just stand on that box and jump off? Because it may be that physically it's no more demanding than the squat, but they may not have the confidence. Oh, I can't possibly do that. I'm a back sufferer. I've got to take care of my back. That's not what we want. We want that psychological confidence. So we need to build both physical and psychological resilience. So using our bending example then, we said initially you're going to bend forward with the back straight because that was the driver of pain. And then we introduced slow, controlled bending, and then we gradually introduced less controlled bending, less predictable bending to try to build up confidence. We increased the weight, the resistance to try to build up strength, and now we're introducing more variables. So we may be introducing speed and power, for example, to try to make them confident psychologically, but to enhance their ability to do a greater variety of movements. And in order to get that variety, we can use lots of different equipment. And if we've got a gym, that's great. If we've got a person who wants to go in the gym and we've got that facility, then we're not limited. But of course, what about those individuals who would never be seen dead in a gym? And what about those individuals who would love to go for a gym but haven't got the money to join or haven't got one locally? We need to be able to increase their movement vocabulary by using things around the house which will challenge them. So it's easy enough to say to somebody, well, I just want you to step up and down on the bottom step of your staircase, but how do we progress that so that it's enhancing resilience? So we need to come up with different movements to try to mimic the challenges, both physically and mentally, that we can easily mimic within a gym. So we're talking about psychology and we're talking about physicality within the movement. So that link between mind and body is important. So we talk about sensory motor training, so a link between mind and body. So we might say to the individual, well, initially it's very slow and very controlled. I want you to do 10 repetitions with that 10 kilo weight, and that's all I want you to do. Or we may say, well, just do that movement until you get a little bit of pain, and when that pain comes, we're going to limit that movement. Now what we're saying is, in stage 2, don't limit yourself when the pain is there. Try and go through the pain slightly. So it's time contingent rather than symptom contingent. So we're using movement as form of an education. So we're saying, well, look, when you said to me that when your back hurts, there must be something damaged. But you've just done that movement and you've said that it did hurt a little bit, but you were able to do it and the pain gradually worked loose. So we're now not having to educate them about hurt and harm. They're receiving that education through experience. So we can use sensory motor effects, so motor imagery, this type of thing can be useful. Perception changes can be useful. Introducing the movement that the patient is fearful of. So talking to the patient and saying, well, okay, you've done a lot of work in the gym, but is there anything that you would like to do that you can't do? Well, I'd love to be able to, I used to pick my grandkids up, throw them in the air and catch them, and it was really great fun. and I wouldn't want to do that now. Okay, well, let's look at that then. Let's look at that as being the end goal. You want to pick a weight up, throw it in the air and catch it, and that weight is moving and it's laughing and it's valuable. So that's where we're going to end up. Well, let's start with a slow controlled movement, throwing something light. Let's do a slow controlled movement, throwing something slightly heavier. Let's do a less controlled movement, throwing something. Let's do a movement with something which is labile, something which actually moves itself. So we're gradually increasing this progression, but using a biopsychosocial approach. So not just using the weight, but using the weight and the situation that is used in. So we're using an example of changing from an exercise which progresses in terms of weight, so a graded exercise, to a fearful movement that we are gradually increasing. So that would be graded exposure. So what do you fear, and how can we reintroduce that gradually? So that graded exposure approach, which we use in pain neuroscience education, is important, because broadly speaking, what we know that pain is a warning system, but we want that warning system to come on appropriately. So in the little bar chart there, we would say, well, after you've had an injury, as you went to bend and stretch your tissue, the pain came on just by looking at the movement. And what we wanted to happen was to go back to how you functioned normally, which was to say, well, when the pain came on, it was because the tissues were being challenged to a point where injury could have occurred. So we're going to perform, and that is known as the Twin Peaks model. So it's something that Butler and Moseley first described many moons ago. But it's something I think most people are familiar with, that pain can come on too early. So it can, tissue can be hypersensitive, or we can have allodynia, where something is painful when it wouldn't necessarily have been painful before. And we're using pain neuroscience education combined with movement to try to tackle that. So graded exposure and graded exercise, and the two would combine. Okay, so for sort of further information on this approach, you've got the paper Back Rehabilitation, the 3R's approach, with loads of different research and bits and pieces in. Many of the concepts that I've used in terms of training are within my various different publications, and please do follow me on social media for any sort of changes and any updates. Thanks very much for listening.